Okay, so my name is Rebecca Fears. I'm the sexual assault nurse examiner. I'm the forensic nurse coordinator at UT Health Tyler. It's a level 1 trauma center here in Tyler, Texas. Tyler is exactly in the middle of nowhere. It's halfway between Dallas and Shreveport, not close to anything. You probably wouldn't wind up in Tyler unless you were actually coming to Tyler. It's the home of Earl Campbell, and we have a rose garden here and a zoo. And that's pretty much it right now. I mean, there's a wine garden and a few other little things in the azalea trail. But that's what you get here. We're about 17 miles from a freeway, and so we don't get a lot of traffic, yet we still seem to hit the map for a lot of things. So in HIV 101, I walked you through a timeline with my experience. I became a registered nurse in 1988, and I walked you through my experience of how I observed the HIV epidemic and how it impacted my life and my career as a practicing nurse at the bedside. This presentation is building on that knowledge, but it's how we get HIV post-exposure prophylaxis for a victim of sexual assault. And folks, this is not easy, and it's not for the faint of heart. I had to deal with a situation this past weekend, and Monday afternoon, I was sitting at my desk, and it was like, this is still hard. Why is this still hard for me? I do this all the time. This shouldn't be hard. I'm going to talk about this week, and I was so frustrated. So I'm going to share some of that frustration with you, and hopefully make it a little bit easier for you and tell you all the things I've done wrong so that you don't have to make those same mistakes. Thank you, Tasa. I greatly appreciate all your support in putting this together. If you have not submitted your resolutions, they are due in a few days. If you don't know how to do that process, please reach out to Tasa. They will take your great ideas and they will make them more wonderful, and you will feel awesome getting the opportunity to do that. It is wonderful. I have 5 children. I have 2 grandchildren, and yeah, I have a huge family. It's wonderful. This is one of my soapboxes when it comes to sexual assault. Some of my colleagues feel like offering HIV prophylaxis is not in their scope, and it's something that's done after the exam, and I completely 100% disagree with that philosophy, and this is how you get it done. So let's back up a minute and let's talk about this. You may hear somebody tell you that most sexual assaults are low risk, and based on the statistics for HIV transmission, and that, well, you don't need to worry about this. So the problem with that statement is that they are looking at this as a sexual assault as a problem for women, and that women are only sexually assaulted by men, and that means that this is a low risk sexual assault, and that's not the case. They're looking at our statistics, and our statistics are problematic because we are not looking at the whole picture. We're only looking at the people who walk into our facilities, and that is not all of the sexual assaults. According to some of our most recent reports, that is only 15 to 21% of sexual assaults that are occurring here in our states. So that is a greatly skewed number. Even if they are low risk, that doesn't mean no risk. For the victim that is at high risk, you need to work out your process for how you're going to do this now. Figuring this out at 2 o'clock in the morning will not be a successful strategy for you. When you do make a plan, you need to test your plan, and then you need to make a plan for how you're going to update this. This needs to be on your calendar every quarter, every 6 months to review, because these organizations change their policies and they don't send you a memo. They change it on their website, and they trust you to go back and check their website for those updates. Obtaining these medications, you have a 72-hour window from exposure, not from when they present to your facility. So from the time of the sexual assault to 72 hours later for the most effective use of this medication. If you discharge them from your facility after your exam, that 72-hour window doesn't start there. So if you discharge them at 3 o'clock in the morning, they're at least 12 to 15 hours post-assault. They're probably closer to 24 or 48 hours and you're telling them that they have to follow up with their physician, I can't get in to see my doctor that quickly. I certainly can't get in to see my doctor, get a prescription sent to a pharmacy, get to a pharmacy, pick it up, and start that medication in that time frame. That's just not realistic. So when if your physician group tells you, oh, we give them a referral to their doctor for the HIV prophylaxis, and in the protocol it says that you can refer them, just explain to them how that doesn't make sense. If you're seeing them and it's been 70 hours since their sexual assault, you need to be giving that first dose during your exam. Is everybody following me with what I'm saying there? Does anyone have any questions about how I'm measuring that timeline? Is there anyone that doesn't make sense to? So the sexual assault happens, the clock starts ticking. You've got up to 72 hours to give that first dose to start them on this medication. That's real important. It's going to vary greatly depending on where you are located inside the state of Texas to how this process works for you. And I am so sorry that I cannot give you a one-size-fits-all answer that's very simple and concise. We're working on it. That's what I'm going to tell you. I promise you that I am doing everything I can, and that the Sexual Assault Survivors Task Force is looking at this as an issue of great concern. I was actually in a conference last week for the International Association of Forensic Nurses. It was our Texas chapter conference, and the KIND Clinic. They spoke to us about HIV prophylaxis, and this was on one of their slides. And this made me so happy, because these are sentiments about HIV post-exposure prophylaxis that I have a hard time articulating to folks, that not all exposures are equal. That anyone who asks for post-exposure prophylaxis should receive it. That post-exposure prophylaxis, that's what that PEP stands for, can be anxiety medication, and that has value. That is very important to our victims that are concerned. And that this is a valuable harm reduction medication. It is very easy for a provider to sit on the other side of the desk and say in a paternalistic manner that they don't feel that it's necessary. But if it is necessary to that victim, then I feel we should advocate for that victim, because they feel it's necessary for them. And this has value to them. This is in the chat box. If you don't see it in the chat box, let us know. But this is the first publication we're going to look at. This is a very concise 8-page brochure. Instead of going to the big CDC booklet, we're just going to look at this brochure. It's much easier to read. Is everybody able to get this link either out of the chat box or off of the screen? Laura, I can see you and Esme and Kelsey, and I can't really see anybody else. Oh, I had something pop up in the chat.
Is it possible to share the link in the chat?
It is in the chat. Are you not able to see it?
I'm not seeing it in the chat.
Oh, it's not in the chat.
Could somebody who logged in earlier pull it out of the chat and share it again?
Yeah, we can see it on the slide that you're sharing, but it's not in the chat. As a participant, I'm not seeing it.
Okay, hang on just a second. I must have shared it in the chat before you logged in. So I'm going to get somebody who logged in earlier.
Okay, thank you.
Got it? So when you pull up that link, this is the document you should see. And if you turn to page 4, these are the 2 regimens that are in there. And the highlighted medications, the first one is Truvada, and the second one is Icentrus. And these are the generic names of them. And I can't pronounce them, so I'm not even going to try. I practiced, and I can't say them. So, and these little abbreviations that you see on the screen, in parentheses, the RAL and the TDF, FTC, this is how they are abbreviated. So they have like 3 names just to make it more confusing for people who don't use them every day. Because why have one name? That would be too simple. So to get these 2 medications, that means that I have to contact 2 different manufacturers, Merck and Gilead. So our first process we're going to look at is our patient who is uninsured. So disclaimer here, right? I cannot prescribe medications. I'm a registered nurse. I'm not telling you that one medication or one regimen that was on that slide is better than another. This is the regimen that my medical director chose. Your medical director with a license to practice medicine may look at those medications and say, we're going to use a different one. You may have an infectious disease doctor in your part of the state that says this is better in our region, and that's perfectly okay. We used this one and I selected it so I could talk about both drug companies that have emergency applications, so that whichever one you need, we could talk about how to do it. Regardless of what regimen that you use, when you're in the exam room and you're giving the first dose, if your victim is female, you may also be providing emergency contraception and STD prophylaxis and HIV prophylaxis. And even if you space those medications out throughout the exam and you feed them, that can be a lot of medication to put on a stomach. So please consider Zofran or Phenergan for nausea, or something for nausea if they need it, because these are very expensive medications and we don't want them to vomit. We don't want to have to redose them, and we want them to stay in their system so that they can be effective. We also want to consider sending them home with a prescription for these, because we don't want them to get home, become nauseated, and then have to return to the emergency room to receive care for that and possibly be redosed, because that would not be very trauma informed or convenient for them or cheap. Giving them the first dose and not delaying it. So if you think about the length of the exam, 4 to 6 hours or possibly longer, depending on how complicated it is, we don't want to wait till the end of our exam to give that first dose. I've seen forensic nurses who have a practice where the patient is seen in the emergency room and then goes to another part of the hospital for their exam, and they discuss these options, and then they go back to the emergency room, and then they're given the medications and discharged, and then they throw up in the parking lot, and they're trying to decide, well, I'm tired, I just want to go home, or do I go back in? And I think it might be more trauma informed and patient centered to give these meds early in the exam, so that if they became sick, they could be treated for that. Do you guys see what I'm saying? Comorbidities might be one of those words, if you're not a healthcare provider, that just wasn't in your vocabulary before our recent pandemic, but that's something you've probably heard and then used over and over and over again. And with this patient, that is certainly something that comes up. If they have major medical illnesses, that is something that needs to be taken into consideration. You might have an emergency room physician that says they're not sure if the standard regimen is appropriate for this patient. Please encourage them to consider the same first dose for everybody. And they can call this National Clinicians Consultant Line. This is a phone, and these are physicians that actually answer their own phone. And they do a doc-to-doc consultation, and they can make adjustments going forward. But the big message here is don't delay that first dose while they figure out what the next best regimen is for them. So this gives us 12 hours to figure that out. This is not a 24/7 hotline any longer, but they do have some extended lines. So this number should also be in the chat box. but this is something you might want to put in your phone. In the past, this has been something that I've relied very, very heavily on. And they've spent a great deal of time helping me sort through a variety of problems. And they've been very, very patient in doing so. So I have a great deal of faith in them and their practice. Did everybody get the number? Can I move on? I can't see anybody nodding, so I'm going to assume that you've got it.
We got it, and it's in the chat box too.
Okay, thank you, Ashley. Okay, so that's the first hurdle. Getting a prescription for this medication, getting the first dose, getting the prescription. Hopefully your ER doctor will prescribe it. If your ER doctor, for whatever reason, is not comfortable doing that, who in your area is? And will they prescribe a medication? And I'd like to tell you that that's the end of your challenges, but it's not. So do you have an HIV clinic in your region? Will they take walk-ins? Can you get their intake forms if you're the advocate? Can you help the victim by filling that out? Because, you know, you can only write down your name, your date of birth, and your address so many times, right? But it'd be really great if your community had the first page of everybody's intake form the same, so that you could just copy that for the victim, right? So you've got the prescription, now what, right? Does your pharmacy have the medications? Is there somebody that will dispense them? Does the hospital you're working at have an outpatient pharmacy? And where were they going to go for follow-up? Because they've got to have follow-up during the 28 days of therapy. So this is how you get the Merck, the Icentrus medication filled. We started with the hardest one first, just so you know. So you're the advocate or the nurse, and you want to fill out the paperwork for Merck, and you're sitting at the computer, so you Google it, because you Google everything in life now, right? So you have two options. You can download the paper form, or you can do a fillable PDF. I caution you with the fillable PDF, because if you fill that one out and print it, you lose your signature prompts because they aren't highlighted on it. So this link should also be in your chat box. And if you're sitting next to a printer and can just print it so you can follow along, that would be amazing. That would help this make sense. Hopefully, if you're listening to this later and it's recorded, just pause and print it. This is where I want you to get to. And we're going to start at the top left, where you see it printed, post-exposure prophylaxis, PEP. I added that. That is not on the form. That's the first thing I want you to do. You're going to find the person with the best handwriting to fill in the patient's name, last name, address. This address must be someplace that they can receive a shipment. It must be very clear. If they're on a county road and there might be issues with a package physically being able to get to them, is there someone, a safe person that they trust, that has a physical address that might be easier for a delivery person to get to? When you get down to that block with the blue star, that first question, do you have insurance or other prescription drug coverage? If the answer to that question is yes, then you cannot use this form. They will not send the medication out. You have to check no there. This is only for persons who answer no to that question. This product has to be shipped to their home or to a physician's office. I have had this shipped to the shelter that the victim was staying at. They recognized that as their home. That worked out well. I did not highlight the yellow boxes on this form. This is how it prints. If you have access to a color printer, which I encourage you to print it just like this, because on the first page, you need the patient's signature twice. No one can sign for the patient here with the date filled in those little boxes. I did add that star at the bottom. They are very proud of the fact that you do not have to be a United States citizen to complete this application or to receive this medication. You simply need an address that they can ship it to. The second page is to the physician. The physician must sign in both places. The nurse cannot sign for him in either place. They cannot use a stamp. The very top of the page is actually the prescription. You cannot attach the prescription to it separately. You cannot make a copy of the prescription and attach it to it. Those are both things that I've tried to do in the past when the physician wouldn't come back and fill this out or had already left and left me a prescription. That didn't work. I did, for my staff, I filled out I checked no on these boxes, and I filled out the name of my facility and our physical address and my office phone number and my secure fax and my name and email address on here on the bottom of the second page, so that for every nurse that works with me that fills it out, if we get any fax from them or any return information, they're calling me because I'm there Monday through Friday. So think of who's the best person that would be available during the day to answer the phone if there were any questions about this. This application works best for your victims who come in during the day. Merck's pharmacy that fills this for you, that drop ships it next day, closes on the East Coast at 4 p.m. So you have to get this in early. My victim this past weekend came in Friday night. So we had to write her a prescription that had enough pills in it to cover her through Tuesday. So that was a separate prescription. And then we were completing this to take her Tuesday to the end of her 28 days. So that was separate funding that we had to locate for her. So that was the problem. It was a Monday morning. Their phones were, I couldn't get through to get approval, even though I had marked it as post-exposure prophylaxis. This is the form that they use. This is, and when you pull up down the directions, you're supposed to mail this in. And it usually takes 48 hours to get approval. Obviously that doesn't work for our patients. When I did get a call back, because you call this number and then you press 1 and then you schedule a call back. When they did call me back, I was able to get expedited approval, and I managed to get permission to send it to the pharmacy, and I had 12 minutes to spare Monday when I got it approved, and I worked on it most of the day. Here are the instructions. It makes it look easy, but again, they want you to mail it in. And you see that this is set up for someone who's HIV positive that's going to be on this medication long-term, because it talks about how many refills. Our patients don't need a refill. And so put this phone number. I write this on, when I print these forms, I write that fax number on all of them. And then I have the nurses save that 1-800 number in their phone under Merck. Because after you fax it, you start calling them, because you want them to pull that fax out of the queue, because it's a post-exposure prophylaxis. And I think this would be a really good place to stop and take questions. And I'm going to go back to that previous slide.
We do have one question in the chat. Since people need an HIV test before given PEP, are you saying they can get the test and then before the results are back, they can get their first dose?
Yes. Most hospitals deliver babies, and most hospitals that deliver babies have the ability to do a rapid HIV test. Ours is literally in the computer listed as L&D stat or HIV stat L&D only when you order it. But because we need our results back today also, we're allowed to use that same testing procedure for our sexual assault patients. So we're putting in the CBC chemistry, HIV rapid, and then the HIV send out. But we're not withholding, because they can always stop the medication, but they can't always, you don't want to lose any time starting it. Are there any other questions? Any questions about this form?
Not in the chat, thank you. If there's any other questions, y'all can unmute yourself.
I have another question. So on the form, it says you mark no for insurance. If they have insurance, can we be tricky and still mark no? Or how does that work if they have insurance but don't want to bill insurance, that type of thing?
At this time, I don't have a workaround for them having insurance that they don't want to bill. I apologize. I haven't been able to locate one. What I encourage you to do is reach out to your community partners for that one. There, let me pull it up on my phone because there's an app for that. Do you guys have Good RX on your phone? So Truvada, I'm looking at Accentris first, sorry. So Accentris runs with a coupon is about $1,600 for 56 tablets. So that would be a pretty big ask from your community partners when you look at what our budgets are for, and that would be per patient.
All right, we have another question. Our hospital does not do rapid tests, although we do test the patient along with the other labs, but we always give the medication. So even if a hospital doesn't have a rapid availability, should it still be the same process?
I wouldn't be the appropriate one to make that decision for your facility. That would be up to your medical director. But from what I'm understanding, yes.
Okay, that is all of them.
Perfect. Okay, so you always have to mark no on this. I can't ethically tell you to lie on anything. That's never a good practice. You need a shipping address that you know that this medication can get to safely. It is available to non-US citizens. Their signatures need to be legible. The printing on this has to be legible. I can't tell you how many times some of my nurses in the middle of the night have scribbled on this, and I've had to field phone calls there because if they're not sure when they look at the address what the numbers are when they read it, they will call before they ship it. They won't ship it if they're not sure. So if they don't print clearly, you know, and I have one of my nurses that I love to death that can't write to save her soul. And you know, it's like, please just get the advocates to fill it out for you. Please don't write on this. And that's what she does. Okay, so this is for Truvada, and this comes from the company Gilead. Again, you go back to Google, you're looking for the Gilead Patient Assistant Enrollment Form, different verbiage to pull it up. It's a little bit more, it's not the first hit, which doesn't make sense to me when you're looking for it. Here's the actual web URL. That's what it's called. It's to say web address, but that's not right. The URL for it. Hopefully it's in your chat box. If not, take a picture of the screen. Again, you can take a picture of any of my slides. I don't care. This is 4 pages long, which at first upset me, but they take the time to explain it a little bit better. When you look at this is page 1 over here on your left. If you list income for this victim, they do want you to attach a documentation for that sources of income. I did get my application that I sent this week to them that did not have anything to sort her $18,000 of annual income. They still accepted it. You do have to start on the top of on your right-hand side now at the top, you do have to add that this is post-exposure prophylaxis. You have to put in the name of the medication that you're requesting from them, whether which is Truvada. There is a place for prevention, but here they just have pre-exposure prophylaxis in the thing. And then I just add that it's PEP. There is a place where you have an alternate contact. If that is not somebody on staff, then I encourage it to be an advocate or someone that will advocate for this patient very strongly. You can, if you can pull this up as a fillable PDF if you want, or you can print it. I pulled it up as a fillable PDF and I put in as much information as I could. I listed myself as an alternate contact with my office information, my facility name. I filled all that out. I put in the diagnosis code. If you don't know the ICD code for sexual assault, it's T76.21. This yellow box that you see at the bottom right, that is not there on the printed form. I added that just to highlight where your physician has to prescribe. I don't know about you guys, but in my emergency room, my physician's schedule, it never fails. The physician that sees my victim when I come in to do an exam is not the person that's on duty when they're discharged. So the person who's prescribing medication may not be there later. So I might need to go get this form signed while that person that saw them is still there. That might be an issue. Again, the yellow highlights on this form I added just to help you see what I'm talking about, because again, it's 4 pages. You need to print the patient's name at the top. I need the patient's signature at the bottom. I need the patient's name printed at the top, and I need the patient's signature at the bottom on the right. It's a little bit longer form, but I mean, they kind of helped you a little bit. Like the fax number is on every page of this form. You do not have to look at it. They are not, Gilead is not going to ship this medication to the patient. They're going to do a callback. If you haven't heard from them after you fax this form, give them a call. They are going to give you, if you were to pull out your insurance card right now, it's going to have a group ID number, a bin number, a lot number, and they're going to be kind of long numbers. They're going to call you back with that information. And I used to give all of that to the victim, and I don't do that anymore. I don't think that's a good practice, because when they call me with those numbers, they kind of overwhelm me. Like I'm repeating them back 2 or 3 times to make sure I got them all right. You can skip a step there and find out what pharmacy the victim's going to. You can call and confirm that that pharmacy actually has Truvada in stock. And then you can call that pharmacy and give them that information. They are very used to working with these companies, and they take that information down. And this is like an insurance card for this company, and the patient can just go in and pick up the medication now. It means that the company's paying for it, so to speak. So this is the longer application, but this is the easier company to work with as far as the patient just being able to go in and pick it up, or the advocate being able to go to the pharmacy and pick it up, which is actually what we did, because my patient didn't live here in town and they met her halfway, so she didn't have so far to drive, which was really nice. Any questions about working with Gilead? You guys are really quiet. Okay. So I was so frustrated Monday with this process that I reached out to another company, and I have not worked with them yet, but they're telling me that I can use their pharmacy. And they have a pharmacy here in Tyler, which isn't open on the weekends, but they're telling me that they can send a pharmacist in that's on call and open their pharmacy to fill these prescriptions for me. And I'm really excited about that. So I couldn't figure out how to take a screenshot when I was also using my mouse to hover to get windows to open. So if somebody wants to email me how to do that, that would be awesome, because I am sometimes technology challenged. But in the state of Texas, this is a list of the cities, and for some reason, Tyler made the list. It is possible that they are near you or would be willing to work with you. They're telling me that they have advocates on staff that I can send them a referral, and that their advocates will help the patients fill out these applications. And if that's how this works, I will be very happy to turn any part of this over to them that they are willing to do. So go on their website, aspcares.com, and see what is available to you in your area, or if you have a 503B pharmacy in your area. So there was a question about insurance. And this is what I found for, because what if you have insurance, but you don't have good insurance, basically, and your insurance has a large copay, and you can't afford the insurance, you can't afford the copay. So they have a grant at Copay Relief, this Patient Advocate Foundation, and it covers the copay for HIV medications up to $7,500 per year per award. So you can call them on their 1-866-512-3861 number if you look at the black star on here. So you have to have a diagnosis. So that's that ICD number that I showed you on the previous screen. They need your insurance information, the number of people in your household, your gross income, the prescribing doctor's name, phone number, and fax, which is on the prescription, the pharmacy name and phone number. You have to have a social security number or an alien ID, so that could be a problem. And they only have representatives available Monday through Friday, 8:30 to 5. And for some reason, all of these businesses are Eastern time. I don't know why. We need to find somebody on the West Coast that wants to do this, I guess. Your advocate and victim could watch this video. It kind of walks you through it a little bit, and your victim could register on their website. There's an algorithm when they register and they go through the website. It's possible that they will automatically be approved depending on the information they put in, and as the algorithm evaluates their answers, as long as nothing is flagged, they could be automatically approved. If they were, then that when they were automatically approved, then that would help them with their copay or cover their copay for them to pick up their medications. If it's flagged for audit, which means something fell outside of the parameters according to the algorithm, then they would have to wait until the next business day that they were open and talk to one of the counselors for whatever was flagged and send in whatever documentation was required. I put this out on several different social media sites when I started putting this presentation together, and I could not find anyone who'd actually used their services. But I spoke with them several times, so I was kind of confused, but I don't know if just nobody wanted to come forward and share their experiences with me. Has anybody here used this organization? Have anything positive to share about them? In talking to them, it sounded like a lot of their monies went towards chemotherapy agents, but they cover a whole host of other medications also. Your patient needs a lot of coaching and support over the next 28 days. It is really easy for them to give up or to decide to discontinue. And that once they start this 28-day regimen, that is not advised. The medication is 2 in the morning and 1 at night. And they just may need some encouragement. They can get this encouragement from their healthcare providers and from their advocates. So please, please, please. I mean, they don't need a phone call every day, but at least every couple of days. If they The most common side effect is fatigue, followed by nausea, vomiting, diarrhea. The side effects are minimal at this time. Great, much less than they have been in the past with these new medications. It is possible that they still might not be able to go to work. Fatigue is still fatigue. If they are on active duty, they are certainly eligible for a profile. If they are on active duty and downrange or in a forward operating base, they absolutely should not be going out on missions. They should not be in 120-degree heat with 60 to 80 pounds on their ruck. So that would not be appropriate. They need to see a healthcare provider 72 hours first week. Somewhere in the midway point for repeat labs, assess for compliance. And I'm ready for the rest of your questions and to go back over anything I sped through or wasn't clear on, guys.
Okay, we have one question in the chat. Is the information on the Copay Relief Foundation nationwide, or is it just for Texas?
It's nationwide.
Great.
You guys are quiet today.
And then for the 101 presentation, yes, TASA posts our recordings on our YouTube channel. So that will probably be available sometime next month along with this one.
Did you have any specific questions about it? I have a few minutes. I can pull that up if you're interested.
Everyone is taking prolific notes right now.
Yeah, like I said, I graduated in 1988, kind of when we really didn't understand AIDS very clearly. I was working in an intensive care unit at John Peter Smith, taking care of an HIV positive patient. And in 1989, while I was 8 months pregnant, I had a contaminated needle stick. So every physician I talked to basically had a different answer for me for what would be best for me and my child. And it was really frightening. And even for years afterwards, they continued to test and tell me it was just a wait and see. And I tried to share that story along with a timeline that's available to you on the Center for Disease Control's website about HIV. As much as we know now about the HIV virus and as much as available, we've hit and miss. You know, we do really good with our grassroots campaigns as far as getting the word out, and then we kind of drop the ball because we've known that needles transmit the HIV virus for a long time, but we still don't have safe needle exchange programs readily available across the country. We know that condoms prevent spread of the virus, but we don't have those readily available in our school systems to all of our children. I think the most current statistic posted on the CDC site was 14% of our adolescents have access to them. But we know that that's the highest risk group for spread right now and with our STDs. Any STD infection or STI infection in adolescents or young adults greatly increases their risk for HIV infection.
Okay, we have a couple questions. Can you scroll back to the Merck slides?
Absolutely.
And then how have you noticed awareness of HIV risk, particularly for survivors, change over time?
Say it again.
How have you noticed awareness of risk for survivors change over time?
That's a complicated question. A lot of victims in the exam room, there's just so much that they're dealing with, and this is just one more thing. like they know that they need to be worried about it, but they don't even know how to process that part of it. A lot of my victims are male. A substantial part of my practice deals with male victims. So that's a conversation that they initiate a lot of times. For my female victims, my victims that are concerned that they were drugged or that there were multiple partners, I don't see the typical acquaintance rape that folks talk about. So I just see a different demographic in my practice. So this is the Merck application. Was there, what specific about it did you want to talk about? Where did my drink go? I lost my Diet Coke. Oh, I wonder if you wanted the phone numbers.
Looks like Angie was wondering if you can go to slide 19, 18 or 19.
So that's 18.
Okay.
This is 19. Oh, did you need the web address for it?
That is in the chat if folks need it. Okay, does Texas have a defendant HIV testing law? And yes, we do.
But let's talk about that for a minute. How would you get that answer within 72 hours to know if you need to start this medication? Getting that answer at some point later on might give you some peace of mind, but I don't think there's any way you can get that answer within 72 hours to start this medication. Can you speak to that a little bit?
No, I agree with you. Yeah, I mean, it's also something that only kicks in at patient or victim request. So it's outlined in our crime victims' rights law, which are enforced via victim request.
Yeah, I can't stress enough when you're filling this out to just force yourself to go line by line and block by block. Everything needs some type of answer, even if the answer is no. Please make note of the phone numbers. This 1-800-727-5400, that is like a patient representative that's going to get you approval. This 1-833-546-0609 is the pharmacy that you are not supposed to fax it to until you have authorization. But having access to all those numbers is very useful. And I don't understand why the number to fax this to isn't on here. But again, this was set up for you to mail it in. And if you're going to be on this medication for the rest of your life, mailing a form in might not be any big deal. But I need this medication as soon as possible. So mailing something in isn't going to help me. Let's see if I can see the chat.
Yeah, I'm not seeing any other questions right now. And again, folks, if you are interested in the PowerPoint, definitely email Rebecca, and she said she would be happy to share it with everyone.
Yeah, print the forms out, sit down with your staff. This is something you don't want to see for the first time at 2 o'clock in the morning.
All right, well, I think that's everything unless folks have any